Good afternoon. Thank you to all my colleagues attending the Hepatorenal 2021 Liver Talks webinar. It's my great pleasure to begin this scientific event today with a liver talks and stage liver disease developing new therapies. It's also a great honor to have my friends from Professor Ângelo Matos from Porto Alegre, who will co-share this roundtable with me, and Professor Kevin Moore from the United Kingdom, who was a fellow with me at the King's College Hospital a long time ago, Prof.ª Guadalupe Garcia-Tsao from the US, and Dr. Giuseppe Grande from Italy, together with the Brazilian friends, which I would like to pass to start this integration to Professor Ângelo Matos to introduce the debaters and the presenters of the clinical case. We also prepare a small tribute to celebrate the Hepatorenal Silver Jubilee. Welcome to the Liver Talks.
15 anos do IFP, Instituto do Fígado e Transplante de Pernambuco, e 25 anos do Congresso Hepato Pernambuco. 2 datas, 2 motivos para celebrar o conhecimento. O IFP tem muito orgulho de participar mais uma vez da organização deste evento, que reúne especialistas do mundo inteiro. Já foram mais de 150 participantes nacionais e 60 internacionais de várias regiões do mundo. Dos 5 continentes que já participaram deste, que já está entre os maiores congressos nacionais na área de hepatologia. Grandes nomes da medicina internacional e nacional já estiveram no evento, o que deixa a gente que somos os nomes por trás do IFP muito orgulhosos e felizes por saber que estamos no caminho certo, o caminho do conhecimento. E é também em nome de todos aqueles que nos ajudaram nestes 25 anos que estamos aqui para agradecer 25º Congresso Hepato Pernambuco e 15 anos do IFP. Conhecimento que ultrapassa fronteiras.
Okay, I'm going to introduce my colleagues, Professor Kevin Moore. Professor Kevin Moore is a professor of pathology of the Department of Education, Division of Medicine, University College, Institute for Liver and Digestive Health. Welcome, Kevin. It's a very nice pleasure to have you in our meeting. You have 1,364 participants in the room at the moment, 100 participants. Please. You're going to talk about the management of hepatorenal syndrome.
Well, thank you very much for that kind introduction, Professor Leila Beltrão Pereira. It's over 30 years ago since we were at King's College London. Seems a long time ago. And it was at that time that I started to investigate the pathophysiology of hepatorenal syndrome. I'm just going to give a brief overview, firstly about the pathophysiology and a little bit about the management to make things clear, because I don't think you can really understand the management unless you know a little bit about the pathophysiology. So to start with, whenever you're faced with a patient with acute kidney injury in the context of liver disease, It's always easy to think this is a patient with hepatorenal syndrome, but it's important to realize that many of these patients may be hypovolemic due to the overuse of diuretic drugs or gastrointestinal bleeding. They may have sepsis. Underlying sepsis is a very common cause of renal dysfunction and is intimately associated, of course, with the pathophysiology of hepatorenal syndrome. Of course, sometimes patients have been started on nephrotoxic drugs. I remember coming in one morning to find that a doctor had started one of my patients with ascites on a non-steroidal anti-inflammatory drug because of his back pain. And of course, the patient had developed renal injury as a result. And then finally, of course, there's a number of patients who will have parenchymal renal disease. So what is hepatorenal syndrome? It's the renal failure that occurs in patients with severe liver disease in the absence of any pathological cause for the development of renal failure. So histologically, these kidneys look pretty well normal, although they may have abnormalities under electron microscopy. And we know from many studies many years ago that if you take a kidney from a patient dying with hepatorenal syndrome and transplant it into a patient with a normal liver, it will function normally. And likewise, if you undertake liver transplant in a patient dying with hepatorenal syndrome, the renal failure will often reverse, indicating an intimate relationship between renal function and liver function in these patients. Years ago, it was shown by Professor Murray Epstein, or Dr. Murray Epstein, that if you undertake an angiogram in patients dying with hepatorenal syndrome, there's very marked renal vasoconstriction. And this shows an angiogram on the left in the same patient while they were dying of HRS. And then shortly after the patient died, a repeat angiogram showed complete normal filling of the vasculature. And then Helmer Ringlarsen and others showed, using a Zeeman washout technique, that renal blood flow falls progressively in patients with cirrhosis. So you can see there's a reduction in renal blood flow in patients with cirrhosis. It falls further in those with ascites, falls further in those with hepatorenal syndrome. But what you can see, actually, of course, is that you have patients with, for example, ascites, but relatively well-preserved renal function, who have a much lower renal blood flow than some patients with hepatorenal syndrome. In other words, it's not purely a renal blood flow phenomenon. It's also a function of how effective that renal blood flow is at extracting or developing glomerular filtration. In terms of hemodynamic factors, there's a number of things that can be happening at the same time. So firstly, it's been shown that patients with hepatorenal syndrome tend to have a lower mean arterial pressure. That's partly because of vasodilatation, but also because their cardiac output is unable to mount an appropriate response, because normally when you develop vasodilatation, the cardiac output increases to try and maintain the blood pressure. And it was shown by Del Arbol and others about 18 years ago that patients who are developing hepatorenal syndrome have a lower cardiac output. And this tied in with the hypothesis that Sam Lee and others have been developing around the fact that patients with advanced liver disease have what some termed a serotic cardiomyopathy. That is, their cardiac function is unable to increase sufficiently in response to either physiological or pharmacological stimuli. And so patients with HRS have impaired cardiac output relative to patients who don't develop HRS. Against this background was also the observation that had been shown many years ago by Vincenzo Arroyo and others, that patients with hepatorenal syndrome have very high circulating levels of norepinephrine or noradrenaline. And this is much higher than patients with HRS, than with ascites or uncomplicated cirrhosis, and is indicative of activation of the sympathetic nervous system. So how does that play out? Because on the one hand, we know that if you lower, if I go back a little bit to this slide here, if you lower someone's blood pressure from a mean of 85 to a mean of, say, 65, you don't develop you don't develop renal failure. So why is that important in patients with HRS? Well, the reason it's important is because of this activation of the sympathetic nervous system, which alters the whole way in which the kidney autoregulates. So in a normal situation, renal autoregulation is designed to prevent significant increases in renal blood flow as your blood pressure increases. Otherwise, every time your blood pressure increased, your renal blood flow would increase. And so renal autoregulation limits that. And it also limits the sudden decrease in renal blood flow over modest decreases of mean arterial pressure. So if you decrease your mean arterial pressure from, say, 80 to around 60, you probably get about a 5% reduction, maybe 10% reduction in renal blood flow. Not enough to make any difference. But if you activate the sympathetic nervous system, this whole renal autoregulatory curve gets shifted to the right. So when you decrease your blood pressure from here, that's a normal value of just over 80 to around about 60, 63 millimeters of mercury, you get a 50% reduction in renal blood flow. So you can see this activation of the sympathetic nervous system is key to changing the whole dynamic of renal blood flow with respect to mean arterial pressure. So the pathogenesis of patients who are developing hepatorenal syndrome is really threefold. There's hemodynamic factors, in which systemic vasodilatation together with a modest reduction in effective cardiac output causes lowering of blood pressure. And this is much more important in these patients because the activation of the sympathetic nervous system alters renal autoregulation and makes renal blood flow much more dependent on blood pressure. And then finally, there's increased formation of a number of vasoactive mediators, endothelins, thromboxanes, leukotrienes, etc. But the role of these, if any, in the pathogenesis of HRS is very undefined. I suspect they have a role in glomerular microcirculatory hemodynamics rather than a macro role in terms of gross renal blood flow. A number of studies now, including the most recent confirmed studies, as well as the original studies by Arun Sanyal and the Barcelona group, have shown, roughly speaking, that about 34 to about 44% of patients respond to treatment with terlipressin and albumin when they're developing hepatorenal syndrome. And in the most recent publication in the New England Journal of Medicine, there were a number of complications that were identified in the group receiving terlipressin and large doses of albumin, which I'll come on to in a little bit. The other thing that was interesting was that before all this was really being looked at in detail, a paper from the Barcelona group showed that if you measure the plasma norepinephrine in patients with HRS before and after treatment with terlipressin, you can completely suppress dramatically the activation of the renal sympathetic nervous system. And that's probably because what happens is the terlipressin alters vascular compliance, it squeezes the blood vessels, it increases the central blood volume, and therefore probably switches off the driver for this for this renal sympathetic overdrive. In other words, what it does is not only does it increase blood pressure, because that's one of the effects of terlipressin, but it suppresses the activation of the sympathetic nervous system, pushing this curve back to the left, making blood flow much more responsive or less dependent on the lowered blood pressure. So you can see it has a double whammy effect, if that makes sense. So now you understand a little bit about how patients develop HRS. The pathogenesis, or rather the treatment, makes a lot more sense. The management has three aims. Treat any underlying precipitating cause. Don't just assume it's HRS. Look to see whether patients are hypovolemic, review their drug chart, take cultures, start antibiotics. Optimize the blood pressure to increase blood pressure, suppress activation of the sympathetic nervous system. And the idea is really to support renal function until there's recovery of liver failure or a liver transplant. realistically, if you've got a patient dying with liver failure, whatever you do to the renal function, if they've got end-stage liver failure that's not going to get better, their renal failure will never improve sufficiently or in a sustained way, and therefore it's probably rather fruitless to treat. So in more detail, you'll identify a patient with an increasing serum creatinine, look at their blood pressure chart, and I emphasize looking and calculating the mean arterial pressure, which is simply the diastolic plus a third of the difference between the systolic and the diastolic pressure. And the reason I say this is because quite often patients with severe liver disease have diastolic hypotension. They may have a blood pressure of 110/40, for example. And quite often you'll find junior doctors will say to you, oh, the blood pressure's okay. And you say, well, what is it? And you get the chart and it's like 110/40. So their mean arterial pressure, you know, is going to be low. What is their temperature? Are they septic? Look for bacterial infection. Take blood cultures, urine cultures, send the societies for microscopy culture. And I actually start antibiotics. And I have done for many, many years, because sepsis is by far the most common precipitant for the development of acute kidney injury in these patients. Stop any medication that impairs kidney function. So I stop all diuretics, and I always start broad spectrum antibiotics, although current guidelines don't specifically recommend that. I remember when we discussed them at the time, it was my view that we should. And then we give current guidelines, still suggest giving some albumin together with 1 to 2 liters of crystalloid, either normal saline or Hartmann solution. Personally, I prefer Hartmann's because it's a balanced salt solution, less likely to cause a hyperchloremic acidosis, but you know, it's neither here nor there. And of course, albumin, ever since the publication of the Itália study by the group here at the Royal Free, led by Alistair O'Brien, has really made, you know, the use of albumin very questionable, really. And I haven't changed the nature of these slides to take that into account, but just emphasize to you that they have reported a higher incidence of respiratory failure and other complications in patients given albumin. And of course, that was also the finding in the confirmed study when patients were given albumin in increasing doses in the US study together with terlipressin. The aim of the terlipressin is simply to buy time to enable recovery of liver function and renal function, providing there's a reversal element. So it's great in patients with, say, severe alcoholic hepatitis, because if they get over the alcoholic hepatitis, everything gets better really easily. How do I evaluate these patients? I look for, we've talked about diagnoses. I now evaluate the organ failure score using the Cliff SOFA score, because we know that patients who have 3 organ failure do worse in terms of getting complications like respiratory failure. I start terlipressin and crystalloids or albumin, and I also check for side effects. So when we start patients on terlipressin, I always do 2 things. I monitor response and monitor them for side effects. So in clinical practice, you've got a patient developing an increase in serum creatinine. You stop the diuretics, look at all their other drugs, stop any nephrotoxic drugs, treat sepsis, give albumin or crystalloids as appropriate. And usually the response is seen within 12 to 24 hours. All the papers talk about 4 days. Realistically, if you don't see a response within 12 to 24 hours, it's not going to work, or it's not working. And you might as well increase the dose. All the papers talk about starting at 1 milligram QDS, and that's in fact the licensing dose. In fact, for years, I've always started at half that dose. I start at 0.5 milligrams QDS. It seems reasonable to start with a smaller dose because we know that smaller doses tend to be safer. And also you'll find that quite a number of patients will respond to a smaller dose. And you can always increase the dose within 12 to 24 hours if there's no immediate response. The great thing about terlipressin bolus injections is they can be given on a general ward, thus avoiding intensive care admission. Or you can give terlipressin as an infusion, which probably reduces the number of side effects such as digital ischemia that patients develop. And I monitor changes in blood pressure, urine output, and serum creatinine. Pretty simple, very practical. In terms of are there any situations in which I'm cautious about using terlipressin, I've already mentioned advanced liver failure, ACLF3. Severe HRS, that's a serum creatinine of greater than 5. Until the confirmed study, I would have treated everyone, all comers, with terlipressin, but it was quite clear that patients with very advanced HRS seemed to do badly on terlipressin, or rather, maybe not do bad is not the right word, but they certainly don't do well. Patients, of course, with ischemic heart disease and, of course, pulmonary edema from any cause. Quite often people ask me, well, since it's an analog of arginine vasopressin, why doesn't it just, surely it would cause severe fluid retention? Well, actually it doesn't. Interestingly, there's 4 studies, and you'll see the orange here is after with terlipressin, and you can see the 4 different studies. There's an increase in urine output in all of them. In some cases quite dramatic. In the Solanke study, from about 300 mils to nearly 1,500 mils a day. And on average, a 2.7-fold increase in urine output. There are a number of complications, but really the most important ones are digital ischemia. It's not usually severe enough to stop terlipressin infusion. It tends to only occur when you get to the very high doses, 2 milligrams QDS. I don't like using doses that high. It's quite a big dose, 2 milligrams 4 times daily, and that's when you get the problems, it seems to me. And usually, if they don't respond much to 1 milligram, you get a bit more of a response by increasing to 2, but not a huge amount. Myocardial ischemia is rare, but of course, if it does occur, you need to stop the terlipressin. About 10% developed abdominal pain. It might be related to mesenteric ischemia, but many patients it's not. I have one patient who, just gets a smidgen of terlipressin, gets just a tiny amount, gets severe abdominal pain, and almost very predictably. We don't really know why or understand why. In a confirmed study, they observed that respiratory failure occurs in 14% of HRS patients. And initially, that was worried. The worry was that this was all terlipressin generated, but it's now clear that that's mainly albumin generated. It's worsened by terlipressin, and we could talk a little bit about the pathophysiology. But the entire study independently showed that the albumin was associated with respiratory failure. When do you stop terlipressin? Well, of course, if a patient recovers their HRS and their creatinine returns to baseline, it's a good reason to stop. If it's not recovering, and certainly by day 4, and I probably would even stop earlier if there was no clear response in terms of diuresis. Then obviously severe side effects like abdominal pain, cardiac ischemia, severe digital ischemia. And of course, some patients will need to go forward or put forward for palliative care. So to summarize, hepatorenal syndrome is caused by a combination of hemodynamic factors, activation of the sympathetic nervous system with increased formation of vasoactive mediators. Treatment includes the removal of precipitating causes, optimization of the blood pressure with terlipressin, and consider renal support or liver transplantation in those in whom there's likely to be recovery of liver function or in whom liver transplant has been agreed and is indicated. So thank you very much for your attention.
Thank you very much, Kevin, for very nice. And now I pass it to Professor Angelo Matos that will introduce our speakers to present the case about hepatorenal syndrome.
Inicialmente, eu gostaria de agradecer à professora Leila pelo convite que me fez. Para mim é um prazer muito grande estar aqui contigo. Já tive em outras oportunidades, mas eu acho que chegar a um jubileu de prata com 25 anos mostra uma resiliência realmente incomum no nosso meio. Os teus eventos, eles são particularmente, extremamente proveitosos e tu lidera um processo que eu considero assim invejável. E por isso, eu gostaria muito de te cumprimentar por mais esse evento que tu estás fazendo. E agradecer mais uma vez o convite. Now, Professor Janaína will present us a case for discussion. Professora Janaína Schiavon é professora de gastroenterologia do Departamento de Clínica Médica da Universidade Federal de Santa Catarina, é supervisora da residência médica em hepatologia do Hospital Universitário, onde atua como médica gastroenterologista e hepatologista da equipe de transplante hepático.
Thank you for inviting me for 2021. Our university hospital is localized in an island called Florianópolis in southern Brazil. We have 42 beaches, and I invite you all to visit us. We are very proud of our champion citizen, Guga Kirten. A 45-year-old male was admitted to our university hospital for increased abdominal volume, dyspnea, and drowsiness. As comorbidities, he complained of active alcoholism and subclinical hypothyroidism. In January of the current year, he was admitted to the university hospital for upper digestive bleeding when he was diagnosed with liver cirrhosis, spontaneous bacterial peritonitis, and severe alcoholic hepatitis that did not respond to corticosteroid therapy. He underwent endoscopic venous ligation. He refers alcohol withdrawal since admission in January. Since then, he is followed up at hepatology outpatient clinic. He was submitted to outpatient endoscopic venous ligation program. Since March, due to renal impairment, diuretics have been discontinued, and he has been submitted to recurrent outpatient large volume paracentesis, approximately 10 liters, with albumin replacement. He was by then classified as child C10 MELD 18. In August 19th of the year of 2019, he was listed for liver transplantation for refractory ascites, MELD 15. Medications in use: spironolactone, thiamine, lactulose, and norfloxacin. His outward creatinine levels varied from 0.7 to 2.8, and sometimes it was necessary to administer IV albumin. As previous exams, he presented a colonoscopy with rectal varix, an upper digestive endoscopy with small caliber esophageal varices, mild hypertensive gastropathy, an abdominal ultrasound revealed liver cirrhosis, no focal lesions, and signs of portal hypertension. On admission, he presented increased abdominal volume, dyspnea, and drowsiness. Because of elevated CRP and leukocytosis, antibiotic and saline infusion were introduced. On the 7th day of admission, he presented kidney injury and received IV albumin. On the following day, he presented facial lesions, and herpes zoster ophthalmicus was diagnosed, and antiviral acyclovir was started. Despite antiviral treatment, renal function deteriorated and hepatorenal syndrome was diagnosed. And we initiated terlipressin 2 milligrams a day in continuous infusion with albumin. 3 days later, we increased the dose of terlipressin to 3 milligrams a day in continuous infusion with albumin. On the following day, the patient complained of dyspnea and cracking rails, and the X-ray showed pulmonary edema. Terlipressin was then reduced, and albumin infusion was reduced to 20 grams a day. On the 17th day of admission, he presented again a deterioration of renal function, elevated CRP, and leukocytosis. Infection was diagnosed with no site, and meropenem was started. On the 21st day of admission, he was admitted to liver transplantation. Infection was controlled with meropenem, and terlipressin was administered. On the follow-up, hemodialysis was not necessary. Initial immunosuppression was done with basiliximab, followed by mycophenolate and tacrolimus. The clinical condition of the patient gradually improved and also did his laboratory tests. He was discharged from the hospital in better general condition with a creatinine level of 1.4 with significant improvement in the peripheral edema. His outward follow-up is as good as expected until today.
Thank you, Janaína. Now the doctors Rodrigo, André, and Alberto will now discuss this issue. Professor Rodrigo Seba é professor adjunto do Serviço de Gastroenterologia e Patologia da Faculdade Federal de Goiânia. Professor André Lira é professor associado e livre-docente da Universidade Federal da Bahia. E professor Alberto Faria é professor associado da Faculdade de Medicina da USP.
Good morning, everybody. Thank you, Leila, for this very kind invitation. It's a pleasure for me to be here today to participate in this special edition of the Hepato Pernambuco. Thank you again. Let's move to the question because we have time restrictions. So the point is that this case illustrates what happened to a patient with a hepatorenal syndrome in which terlipressin associated with albumin decreased the creatinine values, although not to baseline values, but the second episode of a bacterial infection triggered the rise of a serum creatinine. This is in accordance to what was reported by the group of Barcelona, that during bacterial infections in patient with cirrhosis, there is a decrease in the cardiac output, and this may precipitate an episode of the progression of HRS. Yes, the first question, urinary markers have a role. Also conventional and new biomarkers, they may help. In my experience, although the sodium fraction is outside the criteria now, but I have seen that very low values, less than 0.5 of FeNA, are found in patients with hepatorenal syndrome. Maybe the problem is the cutoff, the conventional cutoff of 1.0 is too high to differentiate between pre-renal azotemia and hepatorenal. But also I have used another biomarkers such as NGAL. We are still learning how to interpret them, but it helps to differentiate from acute tubular necrosis from other causes of acute kidney injury. That's it. Okay.
Any mentions to and comments for this question, please?
Thanks, Leila. First, thanks for your invitation. It's a pleasure to be in this meeting again, and congratulations on this 23rd anniversary. I agree with Alberto that FeNA may have a supportive role in the detection of hepatorenal syndrome. It does not have the accuracy to be used as diagnostic test for this purpose because there are some overlaps between ATN and hepatorenal syndrome. However, I think I usually use urinary sodium as a supportive role, and usually urinary sodium is low in hepatorenal syndrome. So I think that's how I would use phenol urinary sodium in terms of helping or adding to the diagnosis of hepatorenal syndrome. And ngelo we don't have here in Brazil yet and needs to be further studied. There are differences in cutoffs in the different populations. It has been more studied in Europe. Recent studies from US also showed a nice predictive value for differentiating HN and hepatorenal syndrome, but still there are some overlaps between the cutoffs. So I think it might aid in the future in managing this type of patients, but it still needs to be more studied.
Good morning. Good morning, everybody. Thank you, Leila, for the invitation. It's a pleasure for me too to participate and congratulate you and your group to this 25 years of Hepatopernambuco. Thank you very much. It's a pleasure. I agree with Alberto and André. It's a typical case of hepatorenal syndrome. And the patient had a very bad evolution after the second bacterial infection, and was transplanted and is very good now. So we know that the liver transplant is finally the only therapeutic approach that can cure the hepatorenal syndrome. The use of terlipressin was very nice. And for diagnosis, Alberto said about the ngelo, we don't have any experience with that. Besides, the studies show that it has a very good differential diagnosis from ATN and hepatorenal syndrome, but we don't have any experience with that. It's interesting that Janaína and her group used terlipressin in continuous infusion. We don't have experience with that. We know that the studies show that the intravenous infusion continuous, we can use a lower dose of terlipressin, and we have lower adverse events. But in our group, we don't have experience. We usually use terlipressin in bolus. So I'd like to ask for the other discussions about this approach. Do you use continuous intravenous infusion or in bolus preferably?
Kevin, how can you use this in London? Only bolus or intravenous infusion, terlipressin?
I think the data is fairly clear. Continuous intravenous infusion shows less side effects. The only problem, of course, is the clinical studies were all done with bolus injections. Having said that, my preference would be to give by continuous intravenous infusion. While I'm speaking, shall I quickly go through the other points in the questions for the discussion? What are my views? Do you want me to?
Yes, please.
So in terms of the urinary markers for the differential diagnosis, by and large, I think, I'll say I think they're a waste of time. I don't see that they're going to make any material difference to clinical practice. At the end of the day, you're trying to find the best way to treat these patients, and many of the treatments we offer will be simply pragmatic and practical along the lines I've discussed, rather than trying to use fancy diagnostic tests, which probably won't change what you do. Fractional excretion of sodium, I don't think helps in the therapeutic decision. It's sometimes interesting to know, but I don't think it helps. In terms of minimum creatinine value, I think the key actually is to diagnose HRS and treat HRS early as possible. The idea that we wait for serum creatinine to go above 1.5 milligrams per deciliter is daft. It was set up when we set up the original diagnostic criteria, and I was part of that grouping, and I think it was a mistake that we made. We didn't really think it through, because it means that all the subsequent clinical studies were predicated almost to fail because they started patients too late. It's a bit like saying we'll only treat patients with bacterial meningitis once they're comatose. It's it would be a nonsense to do that. In terms of effectiveness of terlipressin, yeah, I think the data are very clear. It is more effective than noradrenaline in treating HRS. So I'll stop there.
Okay, thanks, Kevin. Any comments for the other questions, Alberto?
Yeah, I believe that if a patient is already in the ICU and is under therapy with noradrenaline for treating sepsis or septic shock, we usually keep this treatment. We don't change to terlipressin, because although maybe a little bit superior, noradrenaline is useful for treating septic shock. And also, if the patient is in the intensive care unit, we prefer continuous infusion because it's better tolerate and does not increase the cost. The cost is associated with the hospitalization in the intensive care unit. So we don't put a patient in the intensive care unit only to take continuous terlipressin, but if he's already there, we prefer continuous infusion. Is it?
Can I add one other thing? Sometimes when you have a liver patient who's not responsive to terlipressin, or rather not responsive to norepinephrine, and because of tachyphylaxis when they've developed hypotension, you can sometimes switch it to terlipressin to maintain their blood pressure, stop the norepinephrine, and then literally, I've seen some patients where you literally switch them every several days. As one drug wears off, you switch them back to the other drug, and it works quite well in that way, at least in the short term.
Good.
Alberto, one question, please. We know that some people in some little centers of Brazil don't have terlipressin to use in your daily hospital. So is there any option if you don't have terlipressin? How about the use of norepinephrine to substitute terlipressin? What's your experience about that?
The microphone, Kevin, please.
Sorry, there are data clearly that norepinephrine works, and I've seen it work myself. I think the data suggests that it's not as effective as terlipressin. If you don't have availability of terlipressin, then norepinephrine is the next best thing. Midodrine is pretty well useless, and I would never bother using it.
Yeah. Okay, thank you.
It's interesting to point out that there was a paper last year that compared terlipressin with norepinephrine, and terlipressin was superior in these patients with hepatorenal syndrome and ACLF. Although there are meta-analyses that showed they have the same efficacy, but this paper last year from hepatology showed better outcome in patients who used terlipressin.
Maybe important issue to monitor change in blood pressure. Patients that respond usually have an increase in mean blood pressure. So we may add this to the conventional monitoring when using this drug to escalate or to increase the dose of any of these drugs.
Any further comments? If not, you're going to move on. There is one question from Q&A from Luis, but I think he's already answered for the audience.
Can I just make one question very fast, Leila, to Dr. Moore?
Yes, please.
What he thinks about this study that was published in the New England Journal of Medicine, where terlipressin improved hepatorenal syndrome, but did not have any effect on survival rate? Was because it's too late, they introduced too late the drug?
I mean, in the company Mallinckrodt that did that study, the confirmed study, they'd done 2 previous studies, both of which had shown an improvement in survival. It was the confirmed study that was confounded by the fact that in the US, suddenly the use of albumin seemed to skyrocket. There had been quite a lot of studies promoting the use of albumin, primarily from Europe, it has to be said. And suddenly the use of albumin, there were some patients being given like, I don't know, 600 grams of albumin. And in the same publication, in the same issue of the New England Journal of Medicine, the entire study was published, which looked at the effects of albumin on sepsis. And they also reported, I think, about 8% of patients developing respiratory failure, nothing to do with terlipressin. And so what happens is patients who are given terlipressin, they're more likely to develop a respiratory failure. What happens is the venous compliance is abnormal in patients with cirrhosis. When you infuse fluid like albumin, the veins literally just expand. They act like a fluid sump, really. And when you give terlipressin, the venous compliance decreases and the veins constrict effectively. And that increases the effective blood volume and therefore increases the preload on the heart. And then the terlipressin also, by increasing the afterload, because it increases vascular resistance, suddenly in the presence of serotic cardiomyopathy leads to volume overload and pulmonary edema. But you probably won't get this in the absence of the albumin. And it's only in the patients who were given the most albumin develop the most significant problems. So at that point, I'll just stop sharing. So I hope that it kind of explains that. I think you'd find actually I've taken the slide out, but in our hands, when we start terlipressin early, we don't wait for patients to fulfill the old criteria. As soon as you've got a rising serum creatinine, not responsive to fluids, we start terlipressin straight away. And I think over 50% of our patients that we start have got a serum creatinine less than 1.5. And we have something like a 75% of patients will respond. And the majority of those patients will survive. But you have to start it early. If you leave it too late, it's too late.
Right. Before you finish this section, I think Professor Guadalupe Garcia-Tsao has one comment. Please, Guadalupe, can you?
So I did have a comment about the use of urine biomarkers, and I think that at one point the differential between HRS and ATN becomes very important, and then markers of tubular damage like ngelo will be very important to help us make the distinction, because at the end of the day, the two are going to be managed entirely differently.
And also, Guadalupe, hi, how are you?
Hey, Alberto.
What do you think about the very low values of FINA? Because maybe the conventional cutoff is too high. We have seen in patients that are very classical, that we have no doubt in diagnosis. The FINA is very low, usually less than 0.5, not 1. This helps me. And us both help. Any GAL and very low FINA helps in the differentiation.
In a multi-center study that we did here, we found, because we do not have ngelo, we tried to figure out what were biomarkers that could help us in a way to distinguish between the main three causes: pre-renal, ATN and HRS, and FINA. A really low FINA would indicate more towards the HRS, because this indicates very intense renal vasoconstriction. Whereas, like if you have an albumin that's microalbuminuria, may indicate in a very rough way that you have tubular damage.
Okay. Thank you.
Okay, I think, Angelo, I have to have you move on to the next speakers, because the time is, I have to be very precise for the timing.
Ok. La doutora Guadalupe Garcia-Tsao es bem conocida por todos nosotros y no necesita presentación. Con más de 300 trabajos científicos, es una de esas investigadoras que realmente han contribuido a cambiar el comportamiento en la medicina. Es una gran amiga de los hepatólogos brasileños desde hace mucho. La primera vez que estuvo con nosotros fue en la década de 90, Guadalupe. Y desde entonces nunca has negado una invitación para venir a nuestro país. Sus impecables charlas siempre renuevan nuestros conocimientos y para nosotros es un honor y un placer escucharte una vez más. Hoy nos hablará sobre el manejo de la hipertensión portal. Por favor, doctora Guadalupe.
Muchas gracias, Angelo. Angelo fue de los primeros hepatólogos brasileños que yo conocí y desde entonces somos muy buenos amigos. Muchas gracias, Leila, por haberme invitado a esta reunión y felicidades porque 25 años no se dice fácil. Hacer un programa por 25 años es muy difícil. Voy a dar la charla en español y como solo no tengo mucho tiempo, voy a hablar sobre todo del paciente compensado y de los cambios en el paradigma que tenemos en estos pacientes. Como ustedes todos saben, y no necesito saber esto, que con cualquier enfermedad crónica del hígado, el hígado normal se vuelve en un hígado cirrótico. Pero lo que tenemos ahora es un problema muy grande que es las dos etiologías más importantes son el alcohol y el NASH. Y el NASH todo va a ser diferente, incluyendo el síndrome hepatorenal del que hablaban anteriormente. ¿Y cuáles son las complicaciones de la cirrosis? Son dos principalmente, la hipertensión portal, que lleva en su expresión más directa a la formación de varices y hemorragia por varices, pero esa hipertensión también sinusoidal lleva a la formación de ascitis, y cuando hay shunting portosistémico hay encefalopatía. La encefalopatía tiene un origen dual porque participa también la insuficiencia hepática que contribuye a la encefalopatía. Estos dos son de hipertensión portal, este es mixto, y la ictericia es puramente insuficiencia hepática, y de manera que uno va escalando de menos a más. Por supuesto, las pruebas de laboratorio como la albúmina y el INR indican insuficiencia hepática, pero las condiciones clínicas son estas y son las que definen descompensación del hígado. Ahora estoy aquí en Sicilia, de hecho, trabajando con Gennaro D'Amico, y él fue el primero que hizo un estudio muy detenido de los pacientes con cirrosis, donde vio que esta era la sobrevida total, pero que era totalmente diferente en el paciente compensado, donde la sobrevida era muchísimo mejor que en el paciente descompensado. Es decir, la sobrevida del paciente con cirrosis depende totalmente de si el paciente es descompensado o no. Y en este estudio, él describió cuáles son los factores descompensantes más importantes. La ascitis, en el 33% de los pacientes, es esta curva que está aquí, y luego la hemorragia por varices, que es la curva que está aquí, seguida de encefalopatía e ictericia, que siempre son mucho menos frecuentes. ¿Por qué? Porque indica ya que el hígado es insuficiente, mientras que tempranamente hay solo hipertensión portal. Entonces, basados en estos estudios, ahora sabemos que el paciente con cirrosis tenemos que decir si ese paciente es compensado o si es descompensado. Y el descompensado es el paciente que tiene hemorragia por varices, ascitis obvia, encefalopatía no mínima, sino clínicamente evidente, e ictericia. Este es el estadio largo y asintomático, y esta es la descompensación. La sobrevida mediana excede los 15 años en el compensado, mientras que en el descompensado es alrededor de 1.5 años. Entonces sería fundamental poder detener este paso de la cirrosis compensada a la descompensada. Pero por muchos años, como estábamos obsesionados con la hemorragia por varices, porque esto era el resultado directo de hipertensión portal. De manera que en el paciente compensado, nuestra misión como médicos era distinguir entre el paciente que no tenía varices y el paciente que tenía varices que estaban a riesgo de sangrar, con el objetivo de detener el desarrollo de hemorragia por varices. Y este es el estudio del North Italian Endoscopic Club de hace muchos años, que clasificó los 3 factores que determinaban las varices de alto riesgo de sangrar. Era la gravedad de la cirrosis, mientras child A sangran menos, más en el B y máximo en el C, pero sobre todo el tamaño de las varices pequeñas son de color naranja, las varices grandes son de color verde aquí, y vean ustedes que el riesgo máximo es en el child C con varices grandes, sobre todo si tienen estas marcas rojas en las varices, que son áreas donde la varice es más delgada. Entonces, basado en estos factores de riesgo, se decidió que los pacientes que tenían varices grandes, fuese cual fuera la severidad de la cirrosis, deberían de recibir beta bloqueadores no selectivos o las varices deberían de ligar, mientras que aquellos pacientes con varices pequeñas de alto riesgo, es decir, que tenían estas marcas rojas o que ocurrían en un paciente Child C, deberían de recibir un beta bloqueador no selectivo. El primary endpoint en todos estos estudios era detener o prevenir la hemorragia por varices, o sea, solo una de las complicaciones, e incluía tantos pacientes compensados como descompensados. Hace muchos años, cuando yo acababa de llegar a Yale, casi hicimos un estudio muy grande con Roberto Grossman del NIH. La teoría era, ¿qué tal si podemos prevenir que se desarrollen las varices? Y esto fue el estudio de timolol. Eran todos pacientes que eran pacientes compensados que no tenían varices al momento de diagnosticar la cirrosis, se randomizaron a timolol, un beta bloqueador no selectivo, o a placebo. Y encontramos el primary endpoint era el desarrollo de varices, o en su caso, el paciente que se presentaba sangrando. Pero ven ustedes que no hubo ninguna diferencia entre los dos grupos. Pero este estudio nos dio pie a descubrir otras cosas importantes. Por ejemplo, como se medía la presión portal, el HVPG o Hepatic Venous Pressure Gradient, se midió al principio en todos estos pacientes. Encontramos que los pacientes que tenían una presión más alta tenían una menor probabilidad, una mayor probabilidad de estar libres de varices o hemorragia por varices. Estaban a un mayor riesgo de desarrollar varices y hemorragia por varices, y esto era significativo. Entonces, si estos son varices solamente, y si estamos aquí, ¿no? Vimos que la presión portal podía predecir el paciente que iba a desarrollar varices. Y entonces uno se pregunta, ¿qué tal las otras complicaciones de la cirrosis? Y esto llevó a que estudiáramos esta base de datos que teníamos del estudio de timolol. Hicimos un update de los outcomes de estos pacientes, y estudiamos aquellos pacientes que habían desarrollado ascitis, hemorragia por varices y encefalopatía hepática, es decir, descompensación debida a hipertensión portal, y encontramos, como uno debería de pensar, que el gradiente de presión de la vena suprahepática era de más o igual a 10, tenía 4 veces mayor riesgo de desarrollar descompensación que aquellos que tenían un HVPG de 6, lo normal es 3 a 5, 6 ya es hipertensión portal, pero si tienen menos de 10, estos tenían muy poco riesgo. Como ya habíamos demostrado que este mismo HVPG predecía varices, y en otro estudio que predecía HCC, se le llamó a esta presión hipertensión portal clínicamente significativa. Esto está definida con un gradiente de presión de la vena suprahepática de más de 10 milímetros de mercurio, mientras que este otro grupo tenían una hipertensión portal leve. De manera que podemos cambiar ahora este paradigma por decir que lo que llevaba a esta hipertensión portal clínicamente significativa es lo que lleva al paciente compensado a descompensarse, y la complicación principal en realidad, si uno ve las estadísticas de todos los grupos, pero del doctor D'Amico en particular, la ascitis es más importante. Entonces ahora, en vez de estratificar por la presencia y ausencia de varices, estratificamos en el paciente que tiene hipertensión portal leve y el paciente que tiene hipertensión portal clínicamente significativa. Y esto no tiene solamente valor pronóstico, sino que tiene también, es una cosa morfológica. El paciente que tiene cirrosis, pero tiene septos fibrosos delgados, 2/3 partes de estos pacientes con hipertensión portal leve tienen estos septos fibrosos delgados. Es más probable que con un antifibrótico, con un tratamiento etiológico, puedan desaparecer. En cambio, 2/3 partes de los pacientes con hipertensión portal clínicamente significativa tienen estos septos gruesos. Estos septos es muy difícil que se puedan resolver, que puedan desaparecer. Y más recientemente acabamos de publicar este estudio en el que miramos los septos en biopsia. Todos estos pacientes tenían una biopsia hepática Y los pacientes, como ustedes preverían, los que tienen septos gruesos tenían una mayor posibilidad de descompensación, y está definida como ascitis, encefalopatía y hemorragia por varices, que los pacientes que tenían septos intermedios o septos delgados. Ahora, de manera que poniendo todo esto junto, nuestra misión principal es identificar al paciente compensado y prevenir la descompensación clínica. Sin embargo, ahora ya los podemos estratificar. Los estratificamos en aquellos que tienen hipertensión leve, que tienen una posibilidad muy baja de descompensación, y en estos casos el tratamiento etiológico puede llevar a la reversión en un estadio no cirrótico, como les mostré, los septos son delgados, o el objetivo también sería prevenir el desarrollo de hipertensión portal clínicamente significativa. Estos pacientes, como les mostré, están a un mayor riesgo de descompensación, y es en ellos en quienes tenemos que prevenir la descompensación disminuyendo la presión portal. ¿Qué es lo que pasa hemodinámicamente? También son diferentes estos pacientes, no solo morfológicamente, sino hemodinámicamente. Les muestro en rojo la presión arterial media y el índice cardíaco, que son normales en pacientes que tienen hipertensión portal leve, pero ya en el paciente que tiene hipertensión portal clínicamente significativa, incluso aquellos sin varices, ya hay un aumento del índice cardíaco, una disminución de la presión arterial media, que es todavía mayor en el paciente que tiene varices. Todos estos son pacientes compensados, es decir, hay alteraciones hemodinámicas. Y es por esto que en el paciente con hipertensión leve no hay una respuesta clara de los beta bloqueadores, porque los beta bloqueadores reducen la presión portal mejorando esta circulación hiperdinámica. Por lo tanto, los beta bloqueadores no selectivos van a ser más útiles en el paciente que tiene hipertensión portal clínicamente significativa. De manera que, resumiendo todo esto, tenemos en el hígado un aumento en la resistencia intrahepática. Esto lleva a un aumento leve de la presión portal, hipertensión portal de 6 a 10 milímetros de mercurio, pero esto es suficiente para que las arteriolas esplácnicas sientan que hay un aumento de presión, o hay un aumento en la síntesis de óxido nítrico que lleva a vasodilatación, un aumento en el flujo hacia el sistema venoso portal, que entonces aumenta, esa es la circulación hiperdinámica de la que hablamos, aumenta la presión que es leve, la lleva a una presión clínicamente significativa. Es entonces cuando se forman las varices o cualquier otra colateral. Ahora, al mismo tiempo que esa vasodilatación, esto lleva a una hipovolemia efectiva, que sienten los varoreceptores, y esto lleva a activación de sistemas neuromorales que llevan a retención de sodio y agua, hipervolemia. Esto hace todavía una mayor una mayor aumento en el gasto cardíaco, una mayor circulación hiperdinámica, aumenta el flujo aún más. Y adicionalmente, estos sistemas neuromorales contienen vasoconstrictores como norepinefrina, que aumentan las resistencias, quizás al causar vasoconstricción intrahepática. ¿Dónde actúan los beta bloqueadores? Los tradicionales actúan a nivel del flujo. El bloqueo adrenérgico beta 1 disminuye el gasto cardíaco, pero más importantemente es el efecto beta 2 bloqueante, que causa una vasoconstricción esplácnica, de manera que esto disminuye directamente el flujo portal. Por eso es que necesitamos un beta bloqueador no selectivo. De los tradicionales son propanolol y nadolol. El carvedilol es un beta bloqueante no selectivo también, pero que además de tener este efecto bloqueante beta 1 y beta 2, tiene un efecto bloqueante alfa 1, que creemos que actúa vasodilatando estos vasos intrahepáticos y disminuyendo de esta manera la presión. Ahora, hay demostración que bajando la presión portal uno puede prevenir descompensación, y la respuesta es sí. Ese es un estudio en el que miramos a todos los estudios de profilaxis primaria de hemorragia por varices, es decir, todos estos pacientes tenían varices, habían recibido beta bloqueadores o placebos, y aquí les muestro los respondedores a beta bloqueadores. Estos eran los pacientes que habían recibido beta bloqueadores y vemos que los respondedores, es decir, los que habían bajado la presión portal a menos de 12 o más del 20% del basal, tuvieron una menor descompensación. Esto era ascitis, hemorragia por varices y encefalopatía. Las probabilidades de una menor descompensación eran en el orden del 72%. Pero la evidencia más clara de esto resultó del estudio Predesi, que publicó a fines de 2019, justo antes de la pandemia. En este estudio, era un estudio controlado, randomizado, doble ciego, en el que se usaron beta bloqueadores no selectivos, 2/3 partes recibieron propanolol, 1/3 parte recibió carvedilol, y el objetivo no era hemorragia por varices, como habíamos venido haciendo por muchos años, sino que era descompensación, ascitis, hemorragia por varices, encefalopatía hepática y una muerte debida a enfermedad hepática. Y vean ustedes, esos son los resultados principales. El beta bloqueador tuvo una disminución significativa, una disminución casi del 50% en las posibilidades de descompensación. Cuando uno ve cada uno de los, ese es el overall es este, pero la ascitis, que como les mostré es la descompensación más frecuente, fue significativamente menor en el paciente que venía recibiendo beta bloqueadores que el paciente randomizado a placebo. Esto es una disminución del 68%. Y el desarrollo de varices de alto riesgo también fue 40% menor en el paciente que fue randomizado a beta bloqueadores. De manera que estos dos indicarían en un momento dado que uno disminuye la descompensación. Ahora, ¿qué pasó con la disminución de la presión portal? El riesgo de ascitis fue mucho mayor en aquellos que tenían una reducción en el HBPG de más de 10%, solo 6% desarrollaron ascitis, comparados con 24% que no tuvieron una reducción de la presión portal. Nuevamente, entonces, el beta bloqueador baja la presión portal y de esta manera disminuye la descompensación. Ahora, les decía que 2/3 partes recibió propanolol y 1/3 parte recibió carvedilol, y como ven ustedes, el efecto fue mayor, o sea, había una mayor disminución en el desarrollo de ascitis con carvedilol y una menor mortalidad con carvedilol. Esto es un post-hoc análisis, es decir, esto lo hicieron después de haber avanzado todo, no es una comparación frente a frente, pero sugiere que el carvedilol es mejor y que lo hace a través de una disminución mayor en el gradiente de presión de la vena suprahepática, tanto a los 12 meses como a los 24 meses. Ellos usaron carvedilol a una dosis de 6.25 a 25 miligramos una vez al día o propanolol a la dosis habitual, que era de 40 a 160 miligramos 2 veces al día, titulando la dosis a mantener la frecuencia cardíaca a mayores de 55 o la presión sistólica más de 90. Ahora ustedes dirán, ¿cómo vamos a hacer esto prácticamente? O sea, en este estudio, ellos identificaron, todos estos eran pacientes compensados que tenían hipertensión portal clínicamente significativa, es decir, midieron el HBPG y era más de 10 y tenían o no tenían varices o esas eran pequeñas. No podían incluir pacientes con varices grandes porque no hubiera sido ético randomizarlos a un placebo. Entonces, clínicamente, ¿cómo va a ser uno para medir esto y escoger a los pacientes que requieren beta bloqueadores? Pues esto no es práctico, pero ya sabemos que hay marcadores no invasivos de CSPH. Si el paciente tiene varices en el momento de la endoscopía, por definición tiene hipertensión portal clínicamente significativa. Si tiene colaterales portosistémicas en un MRI o un TAC. Y más importantemente, los estudios Anticipate, que son 2, y en el Baveno encontraron que la rigidez hepática, el liver stiffness, por FibroScan de más de 25, o un liver stiffness de 20 a 25, más una cuenta plaquetaria de menos de 150, tienen un efecto muy bueno en predecir hipertensión portal clínicamente significativa. Ahora, en este estudio, en el último estudio de PONS, se encontró que el paciente con obesidad y NASH, estos modelos sobrepredicen la presencia de CSPs, de manera que en este artículo ellos proveen un nomograma donde ustedes pueden calcular, basados en el BMI, basados en el liver stiffness y en las plaquetas, cuál es la probabilidad de este paciente de tener hipertensión portal clínicamente significativa. De manera que en este momento tenemos un cambio en el paradigma en el paciente compensado. Lo que existe ahora es que decimos que el paciente compensado se le hace una endoscopía. Si tiene varices grandes o de tamaño moderado, se les trae beta bloqueadores o ligadura. Si tienen varices pequeñas, los beta bloqueadores son opcionales, y si no tiene varices, se repite la endoscopía cada 2 años. El nuevo paradigma en el paciente con cirrosis es que uno ya no hace endoscopía, uno mide la rigidez hepática, FibroScan con la cuenta plaquetaria. Si hay indicación de que el paciente tiene hipertensión portal clínicamente significativa, se empieza carvedilol, y esto es porque se mostró que tiene un mayor efecto, y hay un metaanálisis que se va a presentar ahora en ICEL, donde se muestra que el carvedilol es más efectivo que el propanolol en prevenir descompensación. En cambio, el paciente que tiene un liver stiffness que no indica hipertensión portal clínicamente significativa se puede medir de manera anual, y esto se discutió en el Congreso de Baveno de hace 2 años. Si el paciente no tolera o tiene contraindicaciones a los beta bloqueadores no selectivos, volvemos al viejo paradigma en el que se le hace una endoscopía. Obviamente, si tiene varices grandes, tendrá que ir a ligadura porque no puede tomar beta bloqueadores. Es súper diferente. El paradigma que existe, el objetivo es prevenir la hemorragia por varices. Este nuevo paradigma, el objetivo es prevenir descompensación clínica, es decir, no solo hemorragia por varices, sino ascitis, que es la complicación más frecuente, y encefalopatía. Y Juan Abrales y yo escribimos esta pieza para gastroenterólogos que está publicada, describiendo toda esta historia que les cuento ahora. Recuerden que eso es todo en pacientes con cirrosis compensada. El paciente cirrótico descompensado, uno vuelve al paradigma viejo. Y la otra cosa que quiero hacer mención es de empezar carvedilol. De manera que, y para concluir, en este momento hemos cambiado nuestra visión. Lo principal que tenemos que hacer el paciente compensado es prevenir descompensación, y más que hacer un screening para ver si el paciente tiene varices o no, uno debe hacer el screening para ver si tiene hipertensión portal clínicamente significativa o no. Esta hipertensión se puede evaluar de manera no invasiva. Sobre todo, lo menos invasivo es la combinación del liver stiffness con la cuenta plaquetaria. Y en estos pacientes, entonces, se pueden usar estrategias para reducir la presión portal. Beta bloqueador es seguro. Ahora estamos investigando el uso de estatinas para tener un adyuvante a los beta bloqueadores para disminuir la presión portal, y con esto prevenir la descompensación, que es mucho más importante que prevenir hemorragia por varices. Muchas gracias por su atención.
Muchas gracias, Guadalupe. Su charla es perfecta. Gustaría de hacer
pero no, perfecto no es nada, pero...
Sí, es perfecta. 2 preguntas para usted.
Sí.
Basado en el estudio predece los pacientes con hipertensión portal clínicamente significativa, los beta bloqueantes son fármacos excelentes y deben ser usados como profilaxis, incluso pré-primária. Creio que esse estudo é fantástico, né? E que editará uma nova era em el tratamento de los pacientes com cirrose.
Sí.
Sin embargo, o maior número de pacientes evaluados tinha VIH-C. E
Totalmente.
esses pacientes não foram tratados. Aunque sabemos que muitos dos pacientes com resposta virológica sustenida permanecem com hipertensão portal clinicamente significativa, poderiam os resultados ser muito diferentes se esses pacientes hubieran sido tratados?
Esto es a lo que me refiero. Justamente el estudio predictivo tuvo que ser descontinuado prematuramente porque se hicieron available el tratamiento antiviral, que fue muy efectivo. Siempre hay que pensar, cuando yo hablo de esto, no estoy hablando del tratamiento etiológico, hablé un poco del tratamiento etiológico. En el paciente que tiene hipertensión portal leve, yo siento que un buen tratamiento etiológico puede incluso revertir la cirrosis. Siempre es muchísimo más importante el tratamiento etiológico. Por eso empecé con decir que es alcohol y NASH. En esos no tenemos, y yo creo que nunca tendremos un tratamiento etiológico propiamente. En hepatitis C yo ya no cuento eso. Vamos a hacer, en el paciente con hepatitis C que ya está tratado, ahora en Sicilia me prestaron unos datos de que uno puede ver las plaquetas, puede ver liver stiffness para ver si el paciente incluso requiere beta bloqueadores o no, porque una vez que se cura el tratamiento etiológico, la presión va a bajar, aunque en el paciente con CSPH, con hepatitis C, que fue tratado, el 80% siguen teniendo hipertensión portal clínicamente significativa. Es súper interesante porque la función hepática mejora, pero la hipertensión portal no mejora. ¿Por qué? Porque los septos ya son muy fibrosos, no se van a ir. Entonces, en esos pacientes todavía hay un lugar para prevenir descompensación. No es tan urgente con un paciente en el que uno no se ha deshecho de la etiología de la cirrosis, pero sigue siendo importante identificar al paciente que puede hacer varices. Sobre todo, lo que es más importante es el paciente que va a hacer carcinoma hepatocelular.
Muy bien.
Angelo, I think I will have some questions from Q&A, but you need to pass to Professor Giuseppe talk and the clinical presentation after you discuss all together. Okay? Yes. 2 questions from the Q&A, and after you're going to present the talk from Giuseppe and the case presentation, and we'll have a 10 minutes discussion for all debaters and moderators to have some comments later on.
Bueno, yo las puedo contestar, las veo en el chat. De Fabio Pache. Esto es interesante. Pregunta si los beta blockers van a ser útiles en la further decompensation. El mecanismo ahí sigue habiendo un mecanismo debido a hipertensión portal, y de hecho usamos beta blockers para prevenir la recurrencia de la hemorragia en el paciente que ha sangrado. Pero para prevenir, por ejemplo, complicaciones como hiponatremia o AKI, yo creo que va a ser difícil que los beta blockers tengan un papel súper importante, porque los mecanismos de esos pacientes ya son diferentes, ya hay más vasodilatación, hay inflamación sistémica, de manera que debe haber otro tipo de medicamentos que pueden ser agregados a los beta bloqueadores en estos pacientes, pero no debe de ser la única terapia. La otra pregunta es de Leticia Nabuco, que pregunta que en los pacientes con hipertensión portal no cirrótica, esto es diferente. Es diferente porque el paciente con hipertensión portal prehepática o presinusoidal, ahí sí que el problema fundamental es la hipertensión portal antes del hígado, no va a haber ascitis. Entonces aquí el problema, la cosa es prevenir hemorragia por varices. Entonces volvemos al viejo paradigma. En el paciente que tiene hipertensión portal no cirrótica, no hay que hacer una endoscopía. Si no tiene varices, no hay que hacer nada. Si tiene varices grandes, hay que dar beta bloqueadores o ligadura. Yo preferiría, como siempre, los beta bloqueadores, pero en este caso en particular es una hipertensión portal que es prehepática.
My intervention is about endoscopic management of variceal bleeding. My presentation is about the role of endoscopy in management of portal hypertension. As you know, the portal hypertension can cause some problems, a lot of problems, and upper GI bleeding is one of the most important issue in this context. From Baveno 6 consensus, we know that the upper endoscopy is useful to diagnose the risk and to have a risk stratification for upper GI bleeding, to understand when you should start the medical or endoscopic therapy, and it's even important to treat acute variceal bleeding. The gastroscopy is the gold standard is in this context, and when you suspect a variceal bleeding, a bleeding in a cirrhotic patient, you can see, you can have the direct visualization of the blood in the esophagus, but sometimes you can see also just the nipple or the clot or the blood in the stomach without a clear source of bleeding. In variceal bleeding, esophageal variceal bleeding, as you know, the portal pressure, the portal gradient is over 10 to 12 millimeter of mercury, and the development of esophageal varices is in up to half of patient with compensated cirrhosis, but in up to 85% of patient with decompensated cirrhosis. In this patient, the rate of mortality and the hemorrhage mortality is very high. Is to prevent the first bleeding. As Professoressa Garcia-Tsao told us, the cure is not the endoscopic ligation, endoscopic procedure, but the cure, the real cure is to try to lower the portal pressure. In some patients in which we can have, start the video, please. We cannot use the beta blockers. Other option is sclerotherapy or the endoscopic variceal ligation. Endoscopic ligation is simple instrument mounted on the endoscopy, and permit us to have an easy examination and to go to the eradication of the varices. In this context, we need 3.5 versus 4 procedure to eradicate varices. Please go on. The video is just to show you what is this kind of instrument of. Okay, go on for variceal bleeding. Variceal bleeding, as reported in Baveno consensus, it's an event, and you should manage with pre-endoscopic, endoscopic, and post-endoscopic attention. So I just highlighted these 2 or 3 important points. The time of endoscopy. All of us in endoscopic department know that when emergency room or also someone from the hospital call you for a urgent endoscopy, and you are very scared in this setting, because sometimes during the night you have to treat an important, a big variceal bleeding. This study, there is a lot of study. This study that it's a retrospective study in 400, more than 400 patients, show us that with this Kaplan-Meier that the primary outcome that in this case is rebleeding plus mortality at 6 weeks. Composite stage underwent urgent endoscopy and go on, Adriano. And in this context, we try to find the best literature, and this systematic review and meta-analysis show us that with the forest plot that rebleeding and mortality is not significative if you have an urgent or no urgent endoscopy. So some group we need a urgent night endoscopy, or we can wait until the morning light, as reported by this article of Di Pietro from England. Acute picture and ulcer again. Endoscopic sclerotherapy is okay. This is a case of massive bleeding during variceal rupture, during which at the beginning we don't see the point of bleeding. So guidelines told us that you can release the first band in the gastroesophageal junction, and also like a blind release. So the blood flow decrease, and you can see better, like in this case, the point of bleeding. So we can suck into the cup the varices and release the ring. So in this case, we stop the bleeding. Avoid to re-advance the scope beyond the varix and band complex to avoid the displacement of this complex. After 2 weeks, 1 or 2 weeks, usually the varices the ring have a sclerotic effect on the varices, and we can we assist to an ulcer and fibrosis. So we can plan other procedure until we have a complete eradication of the varix. Go on, Adriano, please. This is what we not do. So in this case, we saw the varix congested with a scar. In front of you, you can see the scar. If you try to release the band on the scar, the tissue don't go inside the cup, and like in this case, the first band was released in a good situation, but when you come back and try to go in the anti-clockwise and try to have again the suction of the varices, the wall of the varices is stripped, and the band is released in the esophagus. In this situation, other typical approach is endoscopic sclerotherapy that you can use sodium sulfate or polydocanol or absolute alcohol, and you can put with a simple needle into the paravaricial or intravaricial space, each 2 or 3 centimeters. you can use this technique for rescue therapy. Go on, Adriano, please. In this context, we saw that endoscopic variceal ligation versus endoscopic sclerotherapy bring to a better outcome, as you can see in this meta-analysis, for endoscopic variceal ligation. That now is the treatment of choice. Other option is sclerotherapy, scleroligation, sorry. Scleroligation is the combination of band ligation and sclerotherapy inside the variceal band complex. In this context, some trial show us that it could be a good option with faster variceal eradication and no difference in adverse event or bleeding rate. This is a work of 2017 from Monsieur, but in a recent in a following editorial of Lauren Lane, we saw that this meta-analysis is not so reliable, and the combination therapy showed no significant differences in rebleeding, mortality, or endoscopic session to eradication. So we can reserve this kind of option just in a target population. Go on. Other endoscopy rescue therapy are the Blackmore-Sengstaken catheter, that the use of this kind of catheter is lesser than in the past. Self-expandable metallic stent is a new treatment, or EOS-guided injective therapy. And if is not useful to control the bleeding, remember that there are also other approach, not only endoscopy, but also radiological approach that you know very well. Go on, Adriano, please. In this setting, the most used is cyanoacrylate, that is a glue that you can release inside the varices. Have a very good hemostatic efficacy, with more than 94% of patients treated in just one session. And you can use cyanoacrylate and sclerotherapy to lower mortality and rebleeding rate. But we have a lot of adverse event and such embolization, sepsis, or fistula if you release a large amount of glue inside the varix or in the esophageal wall. Go on. So, esophageal stent and start video is a new approach, or better, is an approach with new indication of all the devices that it's available in endoscopic therapy. This kind of stent is designed for variceal bleeding, and it could be used without X-ray or without endoscopy. It's a long traumatic stent, nitinol stent, and you can left it in place up to 14 days. But this is just a bridge therapy to something that could give low the portosystemic pressure. Now is expensive and is not available in all the country. Just a couple of slides to remember that gastric varices is present in 20% of patients with clinical significant portal hypertension. They have low risk of bleeding, but the bleeding is it's difficult to control, and the mortality is high. So the American Association for the Study of Liver Disease and also European guidelines endorse the use of cyanoacrylate as preferential treatment modality for bleeding in gastric varices. Go on. This approach have shown good efficacy and lower bleeding rate. Gastroesophageal type 1 varices using Sarin classification is varices that extend along lesser curve of the stomach. In this setting, you can use the treatment. Most efficacy is the treatment used in the esophageal varices, like band ligation, sclerotherapy, or ultrasound guided tissue adhesive injection. Go on. In the other kind of gastric varices, like gastroesophageal extended along greater curve or isolated varices, you can use other treatment like glue. The glue is best if you release the glue using US. In fact, US allow visualization and puncture of such varices with great ease even in situation with active bleeding or clots or meal in the stomach. You can use the Doppler that enables confirmation of varice obliteration, and have also a prognostic significance. If you reach the complete obliteration, the risk of rebleeding is very low. So you should remember that the most complication, the most frequent complication using embolization is distance embolization. One technique is use coil and glue release. First coil, just 1 or 2 coil inside the varices, and after the glue that take the varices, the coil take the glue into the varices, avoiding the spread in other district. Don't forget also in this case to call if you are unable to stop the bleeding, call the radiologist that can help you. Go on, please. In this setting, I just tell you what is the role of use guide hemostasis. Go on. And also other graphic, please. And remember that acute variceal bleeding is not like an ulcer bleeding, diverticular bleeding. It's a very complex disease that require pre-endoscopic management, and the endoscopist is just a small part of the process. So you should to remember this also to the doctor who refer to you the patient. And I think that a pathologic team should be the leader, the team leader in this contest, and also the endoscopist should follow the indication of a pathologic leader. Okay, thank you very much. Sorry for this pickle problem. Grazie.
Now, Professor Gerson will present us another case for discussion. Professor Gerson é professor da disciplina de gastroenterologia da Uninasal, especialista em endoscopia pela USP e é membro titular da FBG e da SOBET.
I would like to thank you very much, the organizing committee, on behalf of Professor Leila, for the kind invitation. It's a really pleasure to participate with you. I bring you a case of a 57-year-old female that was referred to a pathologist from her general physician for evaluation. She had histories of hypertension, diabetes, obesity, and dyslipidemia. She had no alcohol intake or drugs abuse, and serologic tests were negative. I mean, Hep B virus antigen, Hep C virus antibody, and antimitochondrial antibody. They were all negative. Her body weight was 90 kilograms, and the body mass index was 32.6 kilogram/meter square. Some complementary exams. She had slightly increased transaminases, bilirubin, and INR, and slightly decreased levels of platelets and albumin. She also had an abdominal ultrasound showing an irregular surface and increased echogenesis of the liver with enlargement of the left hepatic lobe and splenomegaly. No ascites were visualized. She has a transient elastography showing a liver stiffening measure of 20 kilopascals, and also an upper GI endoscopy with medium-large esophageal varices with red whale marks and gastric esophageal varice type 2. At that time, a diagnosis of compensated advanced chronic liver disease due to NASH was made. She was a child A6 patient, and they decided to perform endoscopic variceal ligation as primary prophylaxis for variceal upper GI bleeding. I performed 4 uneventful sessions of EVL band ligation in these patients until complete eradication of the esophageal varices. And 8 weeks after the last session of bed ligation, the patient was admitted for hematemesis in other less complex facility. Later in the same day, she was transferred to the ICU of our hospital after performing an AGD on that facility. And this exam identified the eradicated esophageal varice plus a type 2 gall varice with a white nipple sign, which is a small and soft cut on the surface of the varice. That means it has bled recently. General measures for variceal upper GI bleeding were instituted: blood transfusion, antibiotic prophylaxis, intravenous splenic vasoconstrictors, noted terlipressin, and this was followed by the repetition of the EGD. This is the second EGD on our facility. After identifying the white nipple, we performed the obliteration of the GOV2 varice with cyanocrylate in 2 punctions. In the end of the second punction, the varice is palpated with the tip of the catheter with needle out, obviously, in order to check the hardening of the varice, which infers the completely obliteration of the varices. There are some technical issues in the procedure. We have to be very careful not damage the gastroscope. After the procedure, the patient evolved very well. She had no clinical significant decompensation, no hepatic encephalopathy, no ascites, neither any impair in the renal function or jaundice, and she was discharged after 5 days. A non-selective beta blocker, propranolol plus statin, simvastatin, were prescribed for the prevention of recurrent variceal hemorrhage. And EGD follow-up was performed in 4 weeks, and then in 8 weeks, in 3 months, sorry, we can see this whitish material, the extrusion of this whitish material, which corresponds to the glue previously injected. So I have some questions. What's the role of primary prophylaxis for type 2 gall varices bleeding? Is there any predictive factors? What's the best strategy of primary prophylaxis for upper GI bleeding patients with esophageal and type 2 gall varices? Is there any relationship between GOB2 bleeding after eradication of esophageal varices with band ligation? And what's the best strategy of secondary prophylaxis for upper GI bleeding patients with variceal and type 2 gall varices?
Okay, thank you very much indeed, Jason. Thanks a lot. Our former resident, and happy to see his development to debaters and Guadalupe and Giuseppe comments for this case in the practical, in the clinical practice, how you manage these patients.
Okay, to Giuseppe, endoscopic hemostatic powder is an easy procedure requiring mini expertise, show clinical benefit on performance early after admission of patients with cirrhosis and hematemesis. This new strategy may improve the management of these patients, particularly when admitted in centers where advanced endoscopic therapy is not available. What is your opinion about the issue of hemostatic power? Predeci, Guadalupe. The problem we face to put in Predeci, the find of the Predeci study is that most of us do not evaluate the hepatic venous pressure gradient. Do you believe that you could issue liver or spleen elastography in order to identify patients with clinically significant portal hypertension and to evaluate the hemodynamic response to beta blockers, since even carvedilol does not lower the gradient in a significant number of patients?
I think the HVPG is not a clinical tool.
Yes.
So it's good for research. It's good to demonstrate that if you lower portal pressure, you're going to have better outcomes. I am not recommending measuring the HVPG, neither to identify patients with CSPH, nor to follow them once they're on beta blockers. The Predeci study the results are not based on the HVPG. They show the HVPG results just as a proof of concept that patients who reduced the portal pressure had less outcomes. But that doesn't mean that there were patients that reduced their portal pressure or did not, and also did not have outcomes. So the indication, and we're going to have Baveno conference coming up in October, and the recommendation is probably going to be that that you just do the evaluation for clinically significant portal hypertension non-invasively. So for those 3 questions, the first 4 questions in that case, I think that the patient was totally compensated. She had already a liver stiffness of more than 20 and a platelet count of less than 150. So she met criteria for clinically significant portal hypertension. And in fact, she had varices. But you could have just ignored that she has varices. You could have, in our practice, you would have just done the liver stiffness and the platelet count. The patient has CSPH, we start her on carvedilol, and maybe she wouldn't have even had the episode of bleeding. And you adjust the dose based on the heart rate. So you give the maximum tolerable dose of carvedilol or of propanol, whatever you choose. And then that's it. If the patient bleeds, then it's a different story. Now the patient has bled. This is variceal hemorrhage. So you have to contain the treatment in a GOV2. If it's actively bleeding, and I don't know, maybe Dr. Gerson has other opinion. I'm not an endoscopist, but the recommendation that you do a cyanoacrylate glue. And then, you know, in a GOV2, I would probably do a cross-sectional imaging to see if there's a patent spleen or renal shunt or something that could be embolized, or depending on, the patient did not have ascites, so she seemed to be very well compensated. So sometimes the glue may not be enough. So if it's a patent spleen or renal shunt, one could do the balloon retrograde BRTO, trans whatever, I forget obliteration.
Transcatheter.
Whatever. Yes, I forget what BRTO stands for, but the balloon retrograde transcatheter obliteration. Yes.
André, can you comment some things about in your group? How can you manage it after Rodrigo, please?
Yes. Well, for gastric varices, primary prophylaxis, we use beta blockers. I know there are some data about cyanoacrylate being superior to beta blocker, but we follow the Baveno recommendation, and I will ask Guadalupe if she has some insights for us in the new recommendations for primary
I'm sure the new recommendations are going to say what I just told you, that in this particular patient, we wouldn't even do an endoscopy.
All right. So we use here, we use beta blocker for primary prophylaxis for gastric varices. And if there is acute bleeding of the gastric varices, we go for cyanoacrylate. And
if there's a bleeding, if there's an active bleeding, yes. You know, we in the US, we're not as experienced with cyanoacrylate, so we're getting more experience, but to contain the treatment, yes, cyanoacrylate. But there's a nice study in hepatology from China that compares cyanoacrylate versus BRTO. So everybody got cyanoacrylate at the moment of the acute hemorrhage, and then they were randomized to continue just the cyanoacrylate versus BRTO, and the BRTO had a better outcome. So, you know, because cyanoacrylate is in a way like a ligation. If you do a BRTO, you're actually, you know, in a way sclerosing from the inside the gastric varices. So that may be the option, but it depends. We are now, the ASLD is preparing a guidance on tips and BRTO and all these non-endoscopic ways to control variceal hemorrhage, and we'll get data from the literature to figure out what recommendations we can make. But perhaps in a GOV2 that has bled, you do cyanoacrylate glue, and then you decide whether the patient is a candidate or not for BRTO, depending on whether they have ascites, whether they have esophageal varices, what's the liver synthetic function. This patient would appear to be a good candidate for BRTO.
Yeah. May I say some words, Leila?
Sure. Yes, please. I'm passed to you, Rodrigo.
Thank you. I saw the comments that some groups inject cyanoacrylate and also coils. We avoid doing this.
Yes.
In our experience, we saw some extrusion of the coil, and we were afraid. Even several weeks later, the coil was still there. Now, if possible, what I would recommend is GOV2 and nectopic varices. Maybe it's a good idea to get an imaging CT scan to study better the anatomy and to check if BRTO may be performed, or even the embolization of the varices, because endoscopic treatment alone may be not enough, and injecting coils by echoendoscopy. I know that there's a good experience published on that, but maybe dangerous. There's an extrusion of the coil, and many weeks after nothing happened, but maybe these verses are too thin to support a coil.
So the theory when you put the coil in is that the coil just puts the glue together, so there's less likely to embolize.
But to avoid embolization, interlocking coil.
Exactly. So, but you know, again, as in many of there's no randomized controlled trials on which to base, you know, our clinical practice.
Well, there's a group in the United States from Kenneth B. Muller that do this, but maybe there are two things this varies. For the audience, maybe the message that the BRTO is a good option to be considered.
Yes.
Better than this endoscopic treatment alone. And also an image for studying the anatomy in case of GOV2 and ectopic varices is a good idea. This is it.
Rodrigo, you have further comments? Because I have one question for Guadalupe.
A little comment. I'd like to.
Yes, please.
I'd like to congratulate Dr. Jackson for the conduction of the case. Very nice conducted. It's a very difficult condition, bleeding for GOV2 varices. I think that the eradication of esophageal varices previous was very nice because the patient was had a clinical significant portal hypertension, so it was very nice. But the bleeding of GOV2 was very important, and the risk of death is very important in this case. So I think that the glue injection was the best conduct, and if the patient doesn't respond to the glue injection, so I think that the embolization can be a best conduct too. I had a recent case of a patient with a very important bleeding of GOV2 that was embolizated. That was the only approach that we could stop the bleeding. So congratulations for the conduction of the case, Jackson.
Thank you.
I think what time is quite run out, but I have one question for Q&A from Patricia Borges. Guadalupe, do you usually use statin in cirrhotic with portal hypertension without prior discompensation?
The evidence is good in compensated patients that it may prevent decompensation, but these are all a retrospective studies. So we have a propensity match study that showed that in patients with compensated cirrhosis of all etiologies, statins actually decrease decompensation and mortality, but this is all retrospective. I don't think right now with patients with NASH, most of them may be on a statin. So proof of concept studies show that statins decrease HVPG modestly, but improve in a way perfusion of the liver. So that's a good thing. In the compensated patient, I'm confident that statins are going to be beneficial. And we have a huge multicenter trial at the Veterans Administration in the US that's ongoing of statins versus placebo to prevent decompensation. And the NIH just has an RFA out where they have selected, I think, 4 or 5 sites to conduct another multicenter study of statins in the prevention of decompensation. So we have to wait until these trials become available, and it's going to take many years. I think that there is no indication, if the patient does not have hypercholesterolemia, there's no clear indication to give statins. In the compensated patient, in the decompensated patients, it's even worse because these patients have a higher risk of getting rhabdomyolysis. So I would be very careful about using statins in the decompensated patient. There's one trial in patients who have bled. Abrales is the first author, where they randomized patients that had bled. They were on beta blockers and ligation, and they were then added simvastatin or placebo. They did not meet the primary endpoint, and in which was bleeding and mortality. But in mortality, there was a very small effect, beneficial effect on mortality. But based on this, one cannot recommend statins. And the patients, in 3 patients who had jaundice, they had significant rhabdomyolysis. So, I think we have to wait for more trials before we can recommend statins widely, just for cirrhosis itself. If the patient has hyperlipidemia, etc., another indication, it's fine to give the statin. We should not be afraid of giving statins. But I cannot recommend to just give it without any more evidence.
Okay, Angelo, I think you have to close the section and waiting for the Baveno 7 anytime this year, hopefully.
It is. I can tell you the dates. I hope all of you can cannot. I'm sorry.
October this year.
It's in October. It's October. I forget what dates in October. But be aware, it's gonna be. It's gonna finally happen this year. It's gonna be virtual, so you can all attend.
Yeah, I'd like that you all put your camera on. I need to take a photos for the end. And I say thank you very much indeed for all my colleagues, especially Kevin Moore, that who have to left the meeting soon because he had another talks to do. And Guadalupe, that you usually very kind to attend our questions for many times you attend for the meetings. And Giuseppe as well from Italy, and say all my colleagues from Brazil. Special Angelo that co-share with me for this section, and I hope to see you next Tuesday when you're going to talk about liver transplantation. Thank you very much indeed. We have more than 1,300 participation for this section, and it's very glad to celebrate to all of you. Thank you very much. See you next week.
Thank you.
Thank you, everybody.
Bye.
Bye.